Hello, my name is Hope Frost, and on behalf of SBK Healthcare, I'm pleased to welcome you to this webinar recording, Management of DKA Sick Day Rules. Today's webinar is sponsored by Abbott Diabetes Care Division. I'd like to thank our chair, Professor Ramzi Ajjan, and our expert speaker, Professor Pratik Choudhary, who will share an all-encompassing insight into DKA and sick day rules. To find out more about our upcoming and on-demand online and in-person training, please visit www.diabetes-nnf.co.uk. Thank you, and I hope that you find this webinar educational and enjoyable.
So we've got a really exciting day, and I'm particularly excited because the audience is mixed. So we've got different expertise, which is always very helpful. And the other thing I'm excited about, that we've got Professor Choudhary here, who is an excellent speaker. I'm just saying that you will see what I mean. And I've just been thinking about this a few minutes ago, that Pratik and we've known each other for almost 3 decades. I can't believe it. And he was around 7 at the time when I first met him. And I never thought when I first met him that we'll end up doing a session together. So here you go. Life is quite interesting. So in terms of the questions, please make sure that you use the Q&A box. I'll be monitoring that. Feel free to start asking questions as the presentation goes on, and I'll be monitoring that very closely. So I don't want to waste any more time. I'm going to hand over to Pratik. Pratik, the floor is yours. Tell us everything you know about DKA.
Thanks, Ramzi, and thanks for that kind introduction. Yes, it did seem a long time ago when we were in Sheffield. Right. Okay. So thank you again. Yeah. Thanks to SBK and to Abbott for this, and just kind of supporting management of DKA. And when I was asked to talk about this, I did wonder. This is something that people manage routinely every day. I think our hospital has about 200, 300 DKAs a year, right? So it's something that I saw on the chat, a few junior doctors, lots of nurses, people managing it. So let's see what we can say. I hope my hope is that most of this is revision for things that you already know, a couple of ideas, and then maybe some new information that comes through. These are my disclosures, of course. I do work for a number of different companies. So let's start at the beginning. And of course, this is the bit about revision. This is something that you all know. So diabetic ketoacidosis, you've got to have diabetes. And this is defined as a blood glucose of more than 11 millimoles per liter in someone not known to have diabetes, or someone with known diabetes. They don't need to have the high glucose, right? Ketosis, capillary or blood ketones more than 3 millimoles per liter, or urine ketones more than 2+ are on checking. And then acidosis, bicarb less than 18 or pH below 7.3. And just a note there, particularly for I've seen a few of the junior doctors in there, when we go through some people's history, and particularly in the context of someone who you're not sure whether they're type 1 or type 2, we're now looking, of course, a lot more people with where we're questioning the diagnosis. You go back and so they were diagnosed with DKA. And when you look at it, they had the high glucose. They might have had some measurable ketones, but they weren't acidotic. And you go back and say, well, actually, was this really DKA? So to make that diagnosis, you've got to have all 3 elements equally. With SGLT2s, we're getting DKAs. These are people known to have diabetes, but their glucose may not be over 11, and they can still have a defined DKA. So that's the diagnosis. And just kind of a brief word on physiology, and I'll come back to the physiology slide when we talk about what's happening when we're trying to treat people. So if I can just get a pointer up, here we go. So the primary problem with DKA is a lack of insulin. And in type 1 diabetes, of course, this might be because they've not taken their insulin. It can also be a relative lack of insulin, of course. You have an infection, insulin requirements go up, you don't take the insulin, you have low insulin levels. And if I go down the right-hand side of this pathway, one of the main functions of insulin is to put glucose into fat tissue, but also stop fat breaking down. So if there's no insulin around, your fat tissues think, hey, if there's no insulin, it means there mustn't be any glucose. And if there's no glucose, we need to give energy to this person. So they start using the stores, free fatty acids, and start releasing loads of free fatty acids. Those free fatty acids can be burnt by muscles, by tissue, by the brain, and the byproduct of that is ketones. So that's one side of the pathway. The other side of the pathway is when there's no insulin on board. One of the other jobs of insulin is to stop glucose being secreted from the liver. So, and the funny thing is, a lot of these tissues, the only tissue that sends glucose is really the pancreas and the few cells in the brain. Everyone else senses insulin. So when there's no insulin in the liver thinks, hey, there's no glucose about, I better chuck out some of my stores and dump some glucose into the bloodstream. Because the liver can't measure glucose, it can only measure insulin. So the liver then starts dumping sugar into the bloodstream. This insulin also then stops the muscles taking up glucose. The muscles think, hey, there must be no glucose around. Let's start break down muscle into amino acids and dump some sugars into the liver. And so you end up with lots of sugar getting dumped into the bloodstream. So you get hyperglycemia. You get the ketones from the breakdown of the fatty acids. Because it's high sugars, you're going to start peeing out more glucose. The glucose sucks water with it, so you get volume depletion. And along with that, you lose electrolytes, sodium and potassium. So that's kind of a bit of the story about what happens when the primary problem is not enough insulin around, okay? So the next question is, okay, so we know we've got high glucose, we know we're getting ketones. How much ketones is too bad? And there was some work done. This is a while ago, actually, when finger stick ketones came into widespread use. It's around just when I was a first year reg, actually, in 2001. And I remember going to a session by Tara Wallace where they started introducing the idea that, hey, measuring urine ketones, as we've been doing since the 1950s, is a bit outdated. Using a finger prick meter, you can really measure the ketone that's important. And the ketone that's important is beta hydroxybutyrate, BOHB. That's the one that's produced in the blood. In the urine, what we get is a downstream product of that acetoacetate, which is less accurate in a sense. And of course, urine ketones will take a while to develop. So measuring beta hydroxybutyrate is much more relevant to picking up DKA earlier and also monitoring its resolution. The other thing I just wanted to put on in the diagnosis, of course, now with SGLT2 use, we have to be aware of euglycemic DKA, but we also have to be aware of other scenarios that can give you ketones. Because if you're starving, your blood sugar will be low. And so even if I starve for long enough, my blood sugar will start to drop and my body will turn off insulin. And the way I'll survive during starvation is that same pathway I showed you, where the body will, no insulin, start breaking down my muscles and my fat, start making free fatty acids and start getting my ketone levels up. And of course, those people who do the Atkins diet, those people who, run a keto diet, that's the way they run. And sometimes with starvation, if someone's not been eating because of an unwell, you can get starvation ketones, which can be mistakenly diagnosed as kind of, even in people taking their insulin, of course. Same thing happens with alcohol. The main thing you've got to remember is if the glucose is not raised in DKA, you treat everything the same, but we've got to start dextrose from the start so that we can give it the right amount of insulin. And again, I'll come back to that at the end. The other topic I just wanted to mention is ketosis-prone type 2 diabetes. When I was in medical school, in my head, you only get DKA in people with type 1 diabetes. And then I started working in Kings, where we had a large proportion of Afro-Caribbean people, and about 1 or 2 DKAs a month would be in people from the Afro-Caribbean community who actually, you treat the DKA, it would resolve. And they looked like type 2 diabetes. They didn't have antibodies. And actually, you can get those people off insulin. And so we've got to be aware of ketosis prone, mainly in Afro-Caribbean, seen sometimes in Hispanic people. There are also reports of this in Caucasian people as well. So that's just something to remember. DKA doesn't always mean type 1 diabetes. So with that basic start, if we move on to say, let's see, how common is it, or how has it changed, the incidence of DKA, has it changed in the country? So these are data from France, and they looked at the impact of a starting CGM, and in France, this was mainly the Freestyle Libre system. And what you can see at the bottom there, you can see on the left-hand side, type 1 diabetes, the right-hand side, type 2, pretty large numbers, 30, 40,000 people. The blue bars tell you the rates of DKA and hyperglycemia in people the year before they started CGM. And the yellow bars tell you about the rates in the year after they started CGM. And you can see that there's about a 50% reduction in both type 1 and type 2 diabetes in the rates of DKA. You can also see that in that cohort of 31,000 type 1s and 40,000 type 2s, the rates of DKA without CGM are about 4.5%, right? So that'd be 1 in 20, dropping down by half to 1 in 10 to less than 2%, lower than 50, really, people with in type 1 diabetes. And if you go across to type 2, you can see overall rates are lower, but with the same relative reduction. So it gives you a feel for, if you know the number of type 1s or type 2s in your area, how many DKAs you'll be getting. So although CGM reduces the rates of DKA in people who've got it, we're not seeing reduction in the overall numbers of people having DKA. And on the left, I've got data from Sweden. And you can see between 2001 and 2016, the rates of DKA rose a bit and then were pretty steady. Now, maybe we've not seen the drop. These data, 2016 is still 10 years ago. And maybe with wider access to technology, those rates have dropped. But if you look at the data on the right, this is a bit more recent data from Switzerland. And they didn't look at rates across different years, but they looked at rates in different age groups. And as you'd expect, the highest rate of DKA is in those young teenagers. And we know that's a particularly difficult age to have diabetes. And then the rate in type 1 diabetes seems to reach a kind of steady state of about 2%, 2 per 100,000 person years, as you get through to older patients. But if you look at the lighter, the grayish dots, that shows you the rates in type 2 diabetes. And in type 2 diabetes, it's as people get older, as they have lower reserve, maybe reflecting burnt out type 2 diabetes, maybe reflecting some people with older onset type 1 diabetes who are misdiagnosed as type 2. But there is that little rise of incidence in people beyond 70 that they're seeing in the Swiss data. There was a recent paper here looking at SGLT2 driven DKA, just to specifically focus in on SGLT2 related euglycemic DKA. And you can see that the proportion or incidence is pretty low. It's 0.2 to 0.3% across all the different studies that they've done. But of course, when you think about the number of people prescribed these drugs, those add up to a number of events that we will be seeing in our clinics and our hospitals moving forward. Some more data from the French group. Again, they found that as I said, about 4.5% of type 1s reported DKA in the last year. And this is despite a high technology user. So you can see that's about 95% on CGM and 42% on pumps. 22% of those were on closed loop. But the important stat they found was, of those 4.5% of people out of the 2,500 that had DKA, a quarter of DKAs happen. 25% of those people have recurrent DKAs. And so there's something particular about those people, predominantly mental health issues, that are driving recurrent DKA. And you'll all know from your clinics, people who come back 5, 10, 15 times a year, and it's important to have a separate profile or pathway for those people. If you look at euglycemic DKA, as I said, about 10% of DKA now is euglycemic. And what they found is people identify it later because you don't have the high glucose. That's the most common marker for DKA. But once they get to hospital, they have a similar length of stay. So working with Ramzi, we've just been involved in a project where we've used UK data, and CPRD is a big database with 16 million UK population from GP practices. And we can link that primary care data with hospital episode statistics, or HES, and the national database for ONS, which tells us about mortality. So we looked at that data working with Ramzi there, and in that cohort, out of those 16 million people, there were about 80,000 with type 1 and about almost 600,000 people with type 2. And if you look at the rates of DKA there, it's 51 per 1,000 patient years, or maybe that's 5 per 100 patients. So similar sort of rate that we saw in the French population, the type 2 population, much lower rates of DKA. But again, looking at those, the purple with DKA, we had a number of people with recurrent events there over that 7-year follow-up. And within that group, what we found was that the CCI is a measure of comorbidity. So the more comorbidities they have, the more likely they are to have DKA. So if you're relatively healthy with your diabetes, probably low risk. But if But if you've got a lot of other conditions, you've got much less physiological reserve, that might be what tips you into DKA more commonly. So reiterating the point that there's still a large number of recurrent DKA, I wanted to bring up to the factors that can lead to DKA. So if you've got someone with type 1 or type 2 diabetes, things that might have precipitated their DKA is prolonged exercise or fasting. And then you've got liver disease, pancreas disease, probably the most common precipitating factor is infection or sepsis. In young adults, we do see quite a lot of DKA related to alcohol or other substance misuse. And then, of course, you've got surgery where people are kept nose by mouth, or people who are diagnosed as type 2 but actually are late onset type 1. Those are probably the commonest reasons for DKA. If we look at the data, mortality is a big issue with DKA. There's about a 5% mortality per episode, which rises to 23% in recurrent episodes. And this chart on the left here describes all the causes of mortality at different age groups. And you can see that in the younger population, DKA is a really important source of preventable cause of mortality in younger people. The risk of death here, so again, this is work done by Fraser Gibb up in Scotland, showed that these are survival curves after an event of DKA. So if you have one DKA, it's pretty straightforward. You get treated, you get sorted, you get out, and it's an event where maybe you've had a bad infection or it's the oops sort of event. But as soon as you start getting multiple events, and that red line there is people with more than 5 admissions, you can see that their 3-year survival of 800 days is less than 3 years, actually, almost. They've got a 20% mortality. So that's where we really need to focus our attention. And I've just borrowed this slide. That's Chris Garrett in a particularly nice way. He's a psychiatrist who used to work with me in King's and taught me a lot about mental health with diabetes, but he now leads a recurrent DKA service at Barts. And I think they've got a fantastic model where if someone's admitted to the ward with a DKA, they treat DKA like you treat self-harm. So just like if you get someone who's cut their arms, they would not be discharged without review by a liaison psychiatrist who looks at them and then follow up with mental health. If you've had more than one DKA at Barts, my understanding is that you get seen by Chris or someone from his team and then offered mental health support. His work during his PhD, if you look on, suggested that the majority of people with recurrent DKA have some other form of mental illness, and they need support for that as well. He also did this work in his PhD where we looked at the costs of recurrent DKA. And as you have more and more DKAs, of course, each event costs more. But if you look at the pie chart on the right there, you can see that the total cost of those individuals, the DKA cost is less than a third. They also have other inpatient stays, they have emergency room admissions, and they have 30% more cost at outpatients because maybe we're trying to see them and support them. They have other conditions. And so targeting those people is a really important message that I want to give through this session. Okay, so now we kind of have an idea about what DKA is, why it's happened, and how common it is, and we've highlighted the importance of targeting recurrent DKAs, not just putting them on the roller coaster of treat their DKA, get them out till they come back next time. So can DKA, when it happens, is the things that we can do before people get to that stage, and that's fundamentally what sick day rules are about. And so what a lot of the guidelines, if you go to Daphne, if you look at any particular type 1 education programs, they will generally say if your glucose is more than 13.9, check for ketones. If you're feeling ill or nauseous or vomiting, check for ketones. If you've got evidence of fruity smell, check for ketones. But we all know that doesn't happen. So let me put to you, this is probably one of my patients who had a recent DKA, and I saw her after. She'd had a DKA and she came to clinic, and she'd mentioned she'd been in hospital for a bit. And so she's a 21-year-old student. She's kind of left home, 18, come up from, I think, from Exeter. I think she's come up from work, living with us in Leicester, doing a degree here. A1C had been about 8.5%. She's been referred for Daphne for a closed loop pump. She's done Daphne. She's, as a 21-year-old and living that life. And she said she had a bit of a cold for a few days and the sugars were a bit high, but she knows that when you're unwell, your glucose is a bit higher. And the glucose was, sorry, it's not in the morning, it was kind of mid-afternoon. She said the glucose was 17.9 and rising, and she wasn't feeling well. She had an afternoon lecture and she decided, I just feel tired and sleepy. I'll do a correction and I'll sleep it off. She slept through, woke up a bit later, didn't check her glucose because she wasn't feeling that well, didn't do a correction. By the next day morning, she was feeling really sick. She was feeling short of breath. Her friend said, "You look horrible." She measured the glucose, it was unmeasurable, and she then got taken to hospital and had a 3-day stay with DKA. And you can see all the points where this admission, which cost her 3 days in hospital, could have been avoided. And you can kind of guess why. You can see this scenario. Got a young person not feeling well, I've been out at night, 17.9. It's not that uncommon with an A1C of 8.5%. And so she didn't follow the book and ended up in DKA. And so we all know what she should have done. She's more than 17, so she should have checked her ketones. Her ketones, let's say, could have been somewhere like 2 or 3, and she should, and then follow sick day rules if she remembered them from when she did Daphne. And at ketones of 2.1, the sick day rules would have said take 10% of your total daily dose every 2 hours and 100 mils of clear fluids until the ketones are below 1.5. And usually, in my experience, that takes a couple of goes. So let's look at what the sick day rules are. And if I want to recommend where to find sick day rules, what I would do is I'd Google and search for and bookmark the Daphne sick day rules. Okay, because those are the ones that are widely taught. That's what the patient would have been taught when they went to Daphne. So just kind of reiterating, keeping the same system makes sense. So if I walk you through there, you can see at the top there. So if you're feeling unwell and your glucose is high, check your ketones. If you're below 1.5 or negative, have some fluids, keep an eye on them, and do your usual correction, right? Basically, and if your glucose is within target range, then just take the basal insulin. And maybe if you're not feeling like eating, you might increase your basal insulin by a couple of units if you feel unwell, right? So no ketones, just keep correcting basically every 4 to 6 hours, and make sure you're hydrated. But if you have got ketones 1.5 or more, then keep yourself hydrated, but then you've got to check every 2 hours. If you're between 1.5 to 3 on your blood ketone meter, or on urine, if you're 1 to 2 plus, then 10% of your total dose as quick-acting insulin every 2 hours. And if you're going to eat, then take your usual dose on top of that 10%, and then the usual basal insulin. If the ketones are more than 3, though, that's not an immediate go to hospital. That's still a 20% of total dose of supplemental quick-acting, and then take your normal dose if you're eating, normal dose for basal insulin. Keep drinking fluids, and then it's really if you're vomiting or unable to keep fluids down, or if that correction isn't working, that you go to hospital. Okay. So, and just a note for people on pumps, it's slightly more, sorry for this, a bit small, but if your glucose is more than 13 and not responding to corrections, if you stayed 13, you've done a correction, it's not working. If you've got no ketones, keep correcting. Maybe check your infusion site if there's something going wrong. Keep taking fluid, and then that should correct itself. If it's not gone down, maybe increase your background by 20%. So very similar to what you're doing on the pen side, but with the pump. And again, if you're more than 1.5, then check it again, use your pump to bolus, and then if you've got ketones 1.5 to 3, take 10%. If you've got ketones more than 3, take 20%. And there is a section in there, because on the pump you can increase the background insulin, you increase your basal by 30 to 50%, depending on the ketones. Now, of course, in today's world, very few people are on an open loop pump where you have to do this. And so I'll tell you what to do on a few slides down, what to do with a hybrid closed loop system. Again, never stop or suspend your pump. And if you're vomiting or unable, or this system isn't working, then go to hospital. From the patient or slightly more easy to digest side, you've got trend diabetes. I've also got some paperwork on DKA for type 1 and type 2 diabetes. And within that, it might be a little bit easier to explain. So they've got these pictorials: if you're sick, high glucose, fast breathing, sweet or metallic taste in your mouth, and your sugar's high, then take a correction. And they've, rather than say 10 or 20%, they've kind of said, well, if your total dose is, up to 14, 34, 54, they've done the 10 to 20% calculation for you. and then keep every 2 hours. They've got a lower level of glucose here, 11 millimoles. I think that's pretty tight to keep going. And again, the admission is not just for ketones, it's when where managing ketones hasn't worked. So what were the challenges for Alex? Well, that's not complicated for you as healthcare professionals, but for me, or for even her as a pretty bright student. But we do come across people where some of these rules are complicated. You know, it's an algorithm 1.5 to 3, and I can't always remember what I need to do. The other thing that's important is, for most of my patients, if I said take 10%, they'll nod sagely in clinic, but they won't have a clue what that is. And so I certainly take a pointer when I'm revising sick day rules with people. I calculate their total daily dose and I tell them what that 10 or 20% should be. So if you've got ketones, for most people with a TDD of 30 to 50 units, I'll say just take 5 units every 2 hours. And if they're slightly bigger, 50 to 70 units, take 7 units every 2 hours. If they're really big, 100 unit kilos, maybe they're taking 100 units a day, you need to take 10 units every 2 hours. So I'll give them the exact number of 10 or 20%. And so, you know, just again, how do you calculate the total daily dose? Increasingly now, we're realizing that for kind of even standard things like how much basal insulin they take in, what carb ratio they need, what correction factor they need, total daily dose is a really important number for the support of people with insulin-treated diabetes. So in clinic, I would generally always assess someone's total daily dose and say, so I'd say, how much background insulin do you take? And she might say, I take 24. And then I'll say, so over the last 3 days or so, can you think of how much quick acting you did in total? That's all your food, your snacks, and your correction doses all together. So she might say, well, I suppose I take about 8 to 10 for breakfast, 6 or 7 for lunch and dinner. Depends what it is, but it's usually about a 12 or a 15. So for me, that's adding up to 32 background, an average of 8 for breakfast, 6 for lunch, and 12 for dinner. So that's 58 units. So if I round that to 60, what I'm saying is, okay, so if you've got ketones of between 1.5 and 3, you need to be taking 6 units every 2 hours. But if you're more than 3, it's 12 units every 3 hours. And what you realize is if her glucose was 15 or 16, a correction dose might have been 3 or 4 units. So the point here is when you have ketones, the insulin works less well. So you need more insulin than you'd normally take. And that's the mistake that normally happens. Sugars are high, they do a correction. They don't recognize that if the correction hasn't worked, then it's because they've got ketones and they need more. And you might say to someone, if your ketones are 3, I need you to take 12 units every 2 hours. And they go, that's a lot. And you can say, yeah, but if you've got 20%, if you've got high ketones, those 12 units are only working as much as 5 or 6 units without ketones. So that's why you need more. To insulin kills ketones. So we need to get rid of those. So this is what, for those of you who look after people using hybrid closed loop systems, this is the sort of data we get. And for those of you not familiar with this, let me just walk you through. So this is a day from kind of midnight, zero is midnight through till midnight. This orange line is a glucose reading. The green line is kind of our target reading. And on the bottom, it's telling you a bit what the pump's doing. So we can see this person was running pretty high at bedtime the night before. They took a bit of a dose. They put their pump into closed loop mode, which is the blue bit here. And you can see the insulin pump gave them enough insulin and brought them down to target. But then something's happened here. They've either had some food or the pump stopped working or it's got knocked off. And it's still working. And you can see that the glucose started to rise rapidly. And here you can see it flattening out. That means the glucose was more than 22. So when the sugar was there, the person did a pump dose, but he only did a pump dose to correct it. They didn't think that, oh, if I've got ketones, I'm going to need more. And you can see there, actually, nothing really worked. Maybe they got a bit of insulin and it dropped down, but then it went back up again. It stayed up at above 15 for the whole day. And then it's only really this little icon here is when they've changed their insulin pump. You can see now the pump changed and it still takes it 2 or 3 hours to bring the glucose down and get it back into range. And then you can see the second pod fails as well. And they run up and you can see this really vertical rise. That sort of vertical rise usually means you've eaten something and you've had no insulin with it. And you can see there again, they're running high. So if you see someone like this, you've got to be really clear. that this is a pump failure. And this person on the second actually ended up in hospital and then was taken off the pump for a while until we redid some education to get them back. So for people on hybrid closed loop, and for if you're junior doctors, if you're nurse on the ward, on a closed loop, your glucose is almost never over 15. If it is, you've got to ask why. And if you've not eaten in the last 2 hours, then this is definitely an infusion site failure. It means the cannula or the pod going into the body has failed. Because by the time your sugar's 15, the pump has already been giving you extra insulin since you crossed 6. And if it's not been able to bring it down, giving more insulin to the pump is not going to make a difference. So at that point, my advice to everyone is always take a pen correction. That guarantees that you've got the insulin, that kills any ketones that might be brewing, and that starts the glucose coming down. It also means that you now have given yourself 2 or 3 hours to change your set or change your pod. We found a few of our early DKAs in pump patients were when the sugars were high, they'd been 15 or 16 for a few hours. 3 or 4 hours later, said, oh, I've tried to give some corrections to the pump, it's not worked, I'm going to change my pump. So they've changed the pump and put on closed loop. But the pump's brain is telling it that it's given the patient loads and loads of insulin for the last 4 hours. So now it automatically says, I'm not going to give you a lot of insulin, it gives you very little. So when you change the set, the sugar still doesn't come down because the pump isn't giving you any more insulin through the set because it thinks you've got lots on board. And that sometimes has led to DKA, even though the patient has changed the set. That's the reason why I always say do the pen correction. That way you're taking care of some of the insulin the pump thinks it's given. You are bringing glucose down, and then the pump can pick things up a bit later. So, and what I say, I showed you the Daphne 6-day rules, but I'll kind of give you a very simple flow that I talk about in clinic sometimes. So if your glucose is high, check ketones. If the ketones are below 1.5, just do your normal correction. If the glucose is high, but you've got low ketones, I told Alex, your total load is 60, so 10% rate should be about 60 units, and repeat till you get down. And if the glucose is really high, or the ketones are above 3, then take your 20% for Alex, that would have been 12 units. When your glucose is below 1.5, then once you've got it down, you can then go down to this panel, and then when they stop, just stay correction. So you take that 20% until the ketones are down to 1.6, then you can reduce the dose, and then when you get down, you can manage it. I hope that makes sense. So, oops. So all that being said, despite lots of patients in the UK having had proper education, we know that globally, ketone monitoring is really uncommon. And so this is just asking people in different age groups, how often do you measure ketones? And that dark blue line is that 62% of people over 50 said never. 26 to 50, again, half of them said we never do it. It's only the really young ones when it's done a lot, and that's because it's done by mum and dad. Yeah, so that's when you're nauseous and vomiting, and when your sugars are high, again, similar numbers of people rarely check their ketones. Another paper here showing pretty much the same thing. It doesn't matter. We think, oh, maybe it's pump users who are better educated. Maybe is there any factors around, education or deprivation? It's across the board. There's no patient factors that identify why people don't check ketones. So my question is this a physician team factor? This that we as clinicians aren't advising people when to check. Another reason why that might be is the way we talk about it. So, the standard thing we tell the people is if your sugar's more than 13, check ketones. And if they've done it a few times, on the vast majority of occasions, when the glucose is more than 13, you're not going to have ketones. So often I wonder if one of the reasons why there's poor ketone testing is the kind of the boy who cried ketone. Because what we say is, hey, if your glucose is high, check your ketones. And you can see a lady there with pretty high glucose on the trace. You can see usually the glucose is always above 13. And she said, well, I don't check my ketones, and I've not checked them for the last 6 months or a year, and I've been fine. So that's the doctor, the nurse being extra cautious. My glucose is always high. I've been okay. Don't worry about it. And we say you got a bit of risk of ketones, but her lived experiences, I'm not. And these doctors, are always worried, but my diabetes, I don't get the ketones. And when you look at her trace, it's very hard to figure out which of those high glucose readings is associated with ketones and which are just because she's had some background insulin there, so that's protecting her ketones, and she's just not taking a quick acting. And her survival bias would say it won't happen to me. And what we're learning now as we look at studies that look at ketone measurements is that the rise, we always assume that as the glucose goes up, the ketones will go up in parallel. But this study here, the light blue lines are glucose and the dark blue is ketone. You can see in these three individuals, as the glucose goes up, the ketones go up. But this number S20 there, you can see the glucose rising very high, but the ketones not moving at all. Whereas in S23, you can see the glucose was steady, but the ketones rose. So what we're realizing is that glucose and ketones don't necessarily move together. And that's probably the reason why we're moving towards a world where now there's a couple of companies, of course, as a sponsor of this meeting, they have a device coming out, but there is a need for continuous ketone monitoring so we can figure out which of the high glucose ones are the dangerous ones. Because DKA is an important, as I said, it's a cause of a lot of problems. So we hope that when dual ketone sensing becomes available, it might reduce the risk of DKA because it will alert our patients to the impending ketosis, tell them when they need to change their infusion sets or take that extra dose of insulin, and hopefully we can avoid some of the events. What we're seeing is that, we probably get some sort of dual display where we'll see the glucose and the ketones, and we can see how things work. Breakthrough T1D sponsored a meeting with a lot of the great and good of the diabetes world there from around the country. And they created a consensus for how to deal with with continuous ketone readings. And again, what they've said is something between 0 to 0.6, no action required. 0.6 to 1.5, if you've got nausea and vomiting or unwell, you might want to check that your insulin pump is working and make sure you take corrections and try and get rid of those ketones. But if you're above 1.5, that's high. And there, the guidance there, you can say, follow your HCP's guidance, which is monitor sugars frequently, make sure you don't have an insulin pump infusion problem, and take corrections. It does say contact your HCP. And that's something that I'm a bit worried about. This guidance is that it probably means contact your HCP if those things don't work, or if you've got confusion, nausea, vomiting, and abdominal pain. That's probably why it's there. But I don't think any of us want to be contacted every time someone has a ketone of 1.5. And then if you're above 3, of course, you look out for these symptoms and then use the sick day rules that we've talked about to bring this down. I want to mention a point here that when I used to work in London at King's, we had an on-call service for our pump patients as when the service was a bit smaller. And many times you get a phone call at 9 p.m. Doctor, I don't know what to do. My sugar's 18 and I've corrected 3 times. And just say, have you checked for ketones? No, doctor. Okay, check for ketones. What are they? 2.6. Okay. Can you look in your pump and tell me what your total daily dose is? And then you'd walk them through how to look in your pump and find it. Tell them, do a correction, take the DKA rules, your 20% of your total daily dose, and keep monitoring. If it doesn't come down, call me again. And you'll almost never get a second phone call. So that, and I don't know how many DKAs we prevented by having that simple phone call. And it also shows you that although you advise people about the sick day rules, when they're in that scenario where they've got high ketone, they're not well, they find it hard to follow it. And that's something we should always remember. So something else I wanted to talk about when we talked about sick day rules is that sick day rules are not just for glucose, right? And I came across this nice there's a few places where you can find the sad man rules, rather an unfortunate name for these rules, isn't it? But the sad man is if you're feeling unwell, stop the drugs beginning with S and they're SUs and SGLT2s. Stop A is ACE inhibitors, D is diuretics, M is metformin, A is ARBs, and N is NSAIDs. So if someone's not eating or drinking, then these are drugs that should be temporarily stopped until someone is feeling better, and then they should be restarted. And that's the other side, isn't it? Because there's a device in stopping things, but we don't remember when to restart them. So I put this together with the help of our friend ChatGPT, because we often say this when I'm teaching trainees or medical students. DKA, in the vast majority of patients, the failure of education, that we haven't told people how to manage those high ketones, and the difference between getting better in a few hours versus ending up in hospital on a drip is, have you remembered to check your ketones? Have you stayed hydrated? Have you taken that high dose of insulin, that 10 or 20% dose to recover? Or have you ignored it just on your usual corrections, let yourself get dehydrated, and then had to go to hospital to get your IV fluids and insulin and spend 3 days in hospital? Now, so that was a lot about sick dose. When you registered, a lot of you put in a question about what you wanted to hear, and quite a number of people said, can we have an update of how to manage diabetes, DK, and some national guidelines? And I was surprised to hear, are there any national guidelines for DK management? Because actually, the JBDS, led by Ketan Dataria, have done a fantastic document on which, if you haven't got this, put your phones up and scan the QR code, bookmark it, because it really is the most relevant way of managing DKA at the moment. And this is I'm not going to go through this, but there's a one pager that you can print out if you're a junior doctor or a nurse, which kind of tells you what to do in the left-hand side in the first hour, and then in the next few hours, and then later. And it kind of is a pretty rapid review story. It tells you exactly what you need to do. I'm going to just pull out 3 elements of this, and want to get your head around what we're actually doing. So, in the physiology, I said with the absence of insulin, your liver chucks out glucose. So you obviously, if someone's got ketones, insulin kills ketones. So when you give insulin, you're going to stop glycogen breakdown from the liver. You're going to stop the liver producing glucose. That's going to stop your glucose going up. That's why the patient says, even though I'm not eating anything, my sugars are rising. It's because there's no insulin on board, or not enough insulin on board, so your liver's chucking out glucose. It also stops fat breakdown, which is driving the ketones. So insulin will kill ketones. It also starts glucose uptake in both fat and muscle, and inhibits the muscle, contributes a little bit to new glucose, so it helps that as well. So the insulin does those 3 jobs. We also need to give fluids. And as you remember from the sick day rules, the main reason for admission is if you can't keep your fluids down. If you can keep fluids down, most early DK can be managed at home with sick day rules, right? So, or DK can be managed. By the time it gets to A, you're probably vomiting because of the acidosis. So saline corrects your dehydration. And because you're chucking glucose in, you can start to flush out some of the extra high glucose as well in the urine. When we're giving that insulin to turn off the ketones, we're giving a high dose of insulin. And so that you've lost some potassium in your urine, and then insulin is driving potassium into the bloodstream. And so it's low potassium that we're worried about. And on this, I'll just tell you one brief story that I was told when I was a trainee by my boss, Professor Heller, who went to an inquest of a patient. And this is specifically for the junior doctors. There was a young girl admitted to hospital with DK. And, the A&E had done their job. They put the insulin up, 6 units per hour rate, put the fluids up, given her the first few fluids, and they said, check her, transfer to medical ward, hand over to the medical SHO on call overnight, check potassium. That, single junior doctor running around the hospital managing sick patients, instead of that potassium being done at 2 hours, it was done at 4 hours. And potassium was done and sent to the lab. But because that was a junior doctor in a small hospital running around, it didn't get checked for 6. By the time the potassium was checked, the patient had a cardiac arrest and died. So I always tell people, if you're measuring potassium for DK, take it to the gas machine, get the potassium then and there, and adjust the potassium infusion. A DK potassium is not one you send to the lab, because that's just going to cause a 4-hour delay, and you need to take action on that potassium every 2 hours. And then I've got a dextrose up there. You need the dextrose because when you're giving the insulin, you might get the glucose down before you get the ketones down. And you don't want to drop the insulin dose. The insulin is for the ketones. So you give glucose to prevent hypoglycemia. I've just put the chart up here. You can take for the fluids, and there's some standard rules, a liter over 1 hour, then a liter over 2, a liter over 4, and then a liter over 6. And then for potassium, you can see there, if it's over 5.5, nothing, but between 3.5 to 5.5, it's 40 millimoles in the infusion. And if it's below 3.5, you need to really act quickly, because that's when you can have tragic consequences of DK. There are some, in that document, there are some criteria for severity. So ketones more than 6, bicarb really low, pH less than 7, low potassium, which means that you've lost a lot of potassium in your urine, and you're going to have to really use ITU to give high dose of potassium, low GCS or low saturation, and hypotension. So those are really important markers where from the start you want to get them to ITU. Okay, so we've covered a lot of stuff, and I'm just going to have 3 slides to recap a little bit of ketones. So what we're going to do is if the glucose is more than 18, we're going to check ketones. If they're below 1.5, usual corrections. But if they're between 1.5 and 3, for Alex, it was 5 units, and drink some fluids. 2 hours later, you can see glucose dropping, ketones down to normal. Do another using correction, home and dry, sweet. If, however, ketones at the start were 4, the dose is now 10 units every 2 hours. So 2 hours later, she's done the 10 units. 2 hours later, she's going to check. The glucose is lower. Ketones are still kind of in the middle zone now. So I'm going to take another 5 units, take the fluids. Another 2 hours later, glucose is down. Ketones are now, 1.6. I'll still use my DKA rules, not my standard correction. And now the ketones are low. And if you've done that, ketones were high at the start, you've taken your 10 units, but you're nauseous, you're not able to drink, then 2 hours later, you're getting more dehydrated. The glucose is better, the ketones are not quite getting there because you're dehydrated, you're still taking the bigger dose, not feeling better. That's when you say go to A&E, because you can give the insulin at home, but you can't hydrate enough, you need IV fluids. So in summary, I'm going to say education around sick day rules is probably just given at Daphne and it's not repeated, and that's where people forget what to do. Most high readings are not associated with ketones. And so it's really hard to figure out which ones are, which is why we need ketone monitors. But in the absence of that, it's important to think about, are you unwell? Is my standard correction not working? Even if people do recognize ketones, I think the guidelines are complex and most people struggle to do the maths, particularly when they're unwell. And so there's this unmet need to measure ketones and identify dangerous episodes, and for us to simplify sick day rules for our patients. Thank you for your attention. I hope that was useful.
Pratik, that was fantastic. We had so far actually 32 questions, but you answered some of those as we went along. So what I tried to do, I tried to group them together. So the first one, there were concerns over giving the correction to hourly. What if the glucose levels are dropping? So what would you do if the glucose is dropping, but the ketones are not improving? What would you do then?
So you have to take carbohydrates. You know that 100 to 200 mils of fluids that we're talking about? So that might be clear fluids if your glucose is high, but as your glucose comes down below 13, below 10, then that might be orange juice. So that can be liquid fluid with glucose in it. It's in a sense what we do in hospital, right? When someone's on an IV drip, if their glucose drops down below 13, 14, you add in the dextrose, right? So similarly, you give the fluids, but you add up carbs to top it up. Yeah.
And I should stress that, of course, with the ketone monitoring, you'll be doing glucose monitoring.
Monitoring as well, yeah.
Yeah. So let me just ask you, because there were quite a few questions about type 2 diabetes. The first one was, when would you check ketones? At what glucose levels would you check ketones in type 2?
I think it's trickier. So, as I said, you get ketones because there's an absolute relative lack of insulin. So that's why DKA is less likely in type 2, because they generally have their insulin. I think if someone is doing corrections and the sugars aren't coming down, that's one marker. And the second marker is that people are feeling nauseous or feeling like they're vomiting. So the nausea, vomiting, fruity breath, or feeling generally more unwell than they should feel. Often it's, of course, difficult to figure out, isn't it? Because if you're unwell because you've got a cold or a viral infection, you don't know if you're unwell because the ketones, because you're feeling unwell. But I think if your correction's not working, it's useful to check in those people, particularly if they're on multiple daily insulin and if they've got high variability, that's usually a marker they've got less insulin. I don't know, Ramzi, do you have
well, I mean,
advice?
It's a difficult one, but duration of diabetes is one thing. How long have they had type 2 diabetes?
Yeah.
Are they on sort of all the medications, for diabetes, and they've got high glucose levels? Because then you're thinking now they've got beta cell failure. Then everything else that you said really Pratik, and you had to individualize it. Is really very difficult to give a number because a lot of them will be running quite high and quite okay with it.
And actually, so many of our type 2s are now on SGLT2s that relying on the glucose becomes less important. So you have to rely on you feeling unwell to measure ketones. That's the other thing, isn't it?
So that brings me to the next question. It's a really good practical question, saying that, with the new nice guidance and, SGLT2 started earlier, should these people be given ketone meters and educated? And what sort of education? So there was another question of what sort of education we should be doing with these guys.
Yeah, so I think people on SGLT2s, a bit like, what's the rate of, if you think about it, the rate of thrush or urine infections is probably about 1 to 2% on SGLT2s, something of that sort of order. DK is about a tenth less than that, isn't it? I think it was coming out at 0.3, 0.4 per 100 percent, if you like, people. So it's less common than that. But I think awareness, if you're feeling unwell uh, on the drug, I think the Sadman rules kind of apply that if you're feeling unwell, a big marker of feeling unwell is getting dehydrated and not eating and drinking, right? And if you're off your food, you're feeling really unwell, that's a marker that something's not right. Get checked. Should all SGLT2 patients be given keto monitors? I think there's financial implications for that. It's a tricky one. That's when they should know they need to seek help, I guess, is the main thing, and keep hydrated.
Yeah, I think that would be very difficult for them to get ketone meters. But simple education should suffice. I mean, particularly because you're giving it quite early, they will not be insulin deficient. So
Yeah.
risks would be very, very low. Okay, now the other question was about ketosis-prone diabetes that you mentioned, and actually is more common than we think.
Yes.
Some GPs refuse to give ketone meters to these guys because there's a type 2 diabetes in there. What do you do usually? And then I'll tell you what I do.
I don't think I've had pushback, actually, interestingly. I mean, certainly in London, we didn't have pushback to give keto monitors to these people because we know they had DK, they had a DK on their monitor. So I think I don't think I've come across someone where someone's been refused ketone.
I mean, what I do, I don't call it ketosis prone type 2 diabetes. I just call it ketosis prone diabetes, and they need a meter. And
And then either.
that's sort of a way around it. So the last question on type 2 is about long-term sulfonylurea use. Would that increase the risk of DKA because you're exhausting the beta cells, I guess? That was the question.
Okay, so if you're on, so in type 2 diabetes, the natural history is that your beta cells will get progressively lost anyway, right? But when they get lost, you're going to be adding in other medications. And most of those people with beta cell exhaustion will be on insulin at that point. And so, and that's why you saw that peak of you saw the peak of DK in type 2. It actually is really late, isn't it? It's in people late 70s, 80s. Often they're not overweight, they're not obese. The people coming to my mind that I've treated are kind of slim old ladies who've come in with a high glucose and they've had DK. I remember as a registrar in Sheffield, actually, Ramzi, seeing this lady comes to mind. And it really, I said, hang on, but DK happened in type 1s. And this lady is type 2 for 35 years. Why has she got DK? Have I got my diagnosis wrong? And it created a lot of confusion in my mind until I realized that DK can happen in type 2 diabetes in that scenario.
Yeah. And a telltale sign usually that they start losing weight, as you quite rightly said, they're quite small ladies and so on. They start losing weight with the diabetes and high glucose, then you know that they've got beta cell deficiency. So beta cell failure, I should say. So the next set of questions about pregnancy in terms of what is the pregnancy outcome when people get DKAs?
Yes, I think that's really important because broadly speaking, the evidence suggests that fetuses don't like ketones, and so you want to make sure that you minimize the risk of DK in pregnancy. Um, Pregnancy clinic is run by Professor Meek, so I've not done pregnancy or DK. You manage it the pretty same, and the same criteria cutoffs are used in, I think, in the pregnancy world, 1.5 and 3. But I don't know if anyone else on the call has more information. I think we're just definitely need ketones. There's women are faster when they're pregnant to tip over into ketones, and so making sure that and it's because you've got a relative insulin deficiency, if you like, or insulin resistance. So you have to make sure they've got ketone meters, and that it's a very important point. Thank you for raising it. That we need to remind pregnant women about the DK rules, that they don't let it go too far. They pick it up quickly and use their sick day rules to prevent it.
Exactly. It's a good question because yes, it can affect pregnancy outcomes, no question about that. And the other question about pregnancy was the sick day rule the same? Do we follow the
Yes.
same? Yeah. So I mean,
It's just the total daily dose goes up, doesn't it? So you just adjust it to their total daily dose as it climbs through pregnancy. As you know, by the end of pregnancy, people are on about double the insulin they're on at the start. Yeah.
Yeah. So the next question was about HCl. So once they get into DKA, do you just stop the HCl and just move them completely to injections? Would that be safer, or would you continue with the HCl and give the injection? So what do you do in your practice, Pratik?
Okay. So let's separate out sick day rules when someone's at home, right? So the sugars are running high and they've got ketones, right? So at that moment, we know the pump isn't delivering insulin. So it's trying to give insulin, but it's not got in, right? I showed you that case in the trace. In that scenario, you've got to take the pump off, do a pen shot, make sure you're coming down, and then recite everything and get going. And that's usually okay. If they've done that and they've ended up in hospital, at the front door, what you're going to be doing is giving them IV glucose, IV insulin, IV saline, and following the DKA pathway in the drip. Once the ketones are down, or once the person is feeling better, I think it's entirely reasonable to restart them onto their closed loop as quickly as possible, right? The DKA guidelines currently for people on injections say stay on your basal insulin when you're treated, right? So you've got the DK, don't stop the basal insulin, give them the basal insulin, and then when the IV stops, you can then put them on their bolus insulin. And so think of it in the same way for HCl. You've treated the acute thing, they've gone to A&E, when they've come to the medical ward, the ketones are now starting to come down, the glucose is now normalized. I think trying to get them back onto their pump as quickly as possible is, especially if it's a DK that's been caused, for most pump users, it's caused by a pump failure, a set failure that they didn't recognize early enough. So as soon as they're able to self-manage their pump, put them back on again. We are, just for those of you, JBDS, we're working with JBDS. The first author is a very bright young doctor called Pariyavari. I say young doctor, she's a consultant in her own right at Imperial, but she's leading this group on the inpatient guidelines for HCl. And so we've covered it in that document as well. Please look out for that.
We've got only 1 minute, Pratik. Are you worried about hypokalemia outside hospital when you're managing the raised ketones?
I don't think so, because usually outside hospital, in my experience, when we've been on the phone and we've been supporting people to manage it, it's 1 or 2 shots and it's fine. And if they've not got better in 1 or 2 goes, then generally they come into hospital where you're going to manage them. So outside of home, I don't think you get to a scenario where you're that potassium deplete, or where you're giving as much insulin.
Yeah, so I completely agree with you. I mean, the only time I get concerned is they're vomiting a lot, and then they
should come in anyway.
To come to hospital. Very quickly, last question. The cutoff, some people are using 15 millimole per liter as a cutoff rather than the 13.9 for testing ketones. Is that something you're too?
The glucose level is kind of, as we've seen, it's a bit random, isn't it? Because most high readings, if you say 13, you're going to get way more false positives. Where the glucose is high, you measure ketone and it's not raised, right? So you're doing a lot of work, and that's going to be more prone for someone to then give up on it. So, for HCl, we've said 15 for 2 hours. So I'd be tempted to say 15, but if they're on SGLT2s, it's more about how you're feeling. Don't think it's relevant. I think 13 is so common that if you go for that, then
I have to do the BBC and stop you here. I'm sorry, because we are out of time. But honestly, this was absolutely fantastic. I'm not saying that to be nice to you, because I like to be nasty to you if I can. It was absolutely fantastic.
Thank you.
And I would like to thank the audience, because you've been really very, very good. And thank you, SPK, for arranging this, and of course Abbott for sponsoring it. So back to Hope.
Yeah.